Okay, next we're going to go over ostomy care, and hopefully you've already watched a video for piercing skills and understood it. I'm just going to reinforce some things and show you a couple of other things. So the reason we have ostomies is when a patient's had disease, trauma, cancer, that's kept their large intestine, usually the large intestine, it can be small intestine, from functioning appropriately. And for whatever reason, we need to divert the feces from going through the entire intestine. So what I have here on the model is representation of ostomies, to be more specific, stomas that you see on the abdomen. Okay, so here's three. And for the most part, what you see here would be maybe a sigmoid ostomy. Okay, this would be an ostomy that's on the descending colon, and here maybe you have an ostomy that is either on the ascending colon or even an ileostomy, small intestine ostomy. Okay, so if you think about the intestine, the colon absorbs all the fluid, starting with the ascending colon. So the large intestine would be in this area, comes across transverse, descending into the sigmoid, rectal vault, and then out into the toilet. Well, due to disease, what have you, sometimes we need to have that feces come out before it actually goes through the rectum. And depending on where the ostomy is, that determines what the consistency of the fecal material is. So if this was potentially an ascending colon ostomy on the ascending colon, what would happen is the surgeon would take that ascending part of the colon and bring it up through the abdomen, through a hole, through an incision, and then they would create the stoma, so that if they took the rest of the intestine out, okay, there would be nowhere for the stool to go, so it's got to go here. So this could either be taken out, okay, maybe due to cancer, maybe it's due to ulcerative colitis, for whatever reason, okay. But our feces that comes in here is very liquid. So by this point, it would be considered possible diarrhea, maybe starting to form somewhat mushy, okay. If we had a higher level ascending where it's starting into the transverse, or maybe even a ostomy that's on the transverse section of the colon, it may be mushy even as you come down to the descending. As you come to the descending colon, what would come out of this stoma is a more thickened consistency, maybe a little wet, possibly formed, but it would be thicker than what it would be over here. If this was a sigmoid ostomy, which would be in the sigmoid colon, which is where the final reabsorption of water takes place, then you would have a formed, normal-looking stool. Okay, so hopefully you can visualize why someone would need an ostomy. Go to your Tabors and look up ostomy, and you'll get more information about reasons for ostomy, as well as in your textbook. So you can do a little bit of homework on that. But those are the types of stool that you'll see with the types of ostomies. Sometimes if we have trauma, maybe the surgeon wants to take a portion of the transverse or whatever part of the colon out. So if you can imagine the colon being through here, maybe they want this much to be gone. So what they'll do is bring what's called a double barrel stoma or a double barrel ostomy, where you would have something that looked like this. Okay, so that stool would come up and drain out of this pouch, but just mucus would be out of this pouch that the body normally makes. It could come out of the pouch and out of the rectum. Okay, but one pouch would cover both of them. And the reason we would want a double barrel ostomy or a double barreled stoma is because hopefully in about 2 or 3 months, when that portion of the intestine has healed, they can make another incision, go back in, reanastomose the colon, and it would work normal, and the person wouldn't have to have a pouch or an ostomy bag for the rest of their life, and their intestines would work normally. Okay, so when we are actually trying to measure what size pouch, so let me back up a step. you have to have something that covers this securely, okay, so that you can have a pouch to capture the feces, or else it would always leak. Okay, it would leak right onto the patient's abdomen. So we have to make sure we have good skin integrity around the stoma. Stoma should always be pink. It should never have a yellowish. It should never be bright cherry red or black. Okay, so a pinkish color is what you're looking for. The other things can signify strangulation of the actual stoma, which causes lack of blood flow, so it would become pale, and then it would turn a bright cherry red in like one spot, not the whole thing, but in one spot, and then it could turn black. Okay, but we've got to have a pouch here to capture whatever's coming out. So some of our supplies that we have to get to take care of ostomies is we need what's called a wafer. Okay, and your wafers can be made by different companies. Okay, but for the most part, this is a wafer. Okay, sure fit, stoma adhesive. Okay, it's called various things, but if you're in clinical and the instructor says go get me a stoma wafer, this is what we're talking about. Okay, so when you peel this back, this is the portion that goes to the skin. Okay, it's what connects and keeps the skin clean. So this hole here, this is the portion that goes to the skin. So when you're trying to keep the skin around the stoma clean, this has to be somewhat of a tight fit around the stoma. Well, you can obviously tell that that hole right there is not going to be the same size as that actual stoma. Okay, so what we would have to do is we measure the ostomy, and the stoma kits usually have this measuring device. Okay, so it's just this little pouch. You can see that that's way too big. So what you want to do is you want to fit it where it's right around the stoma, but not onto the stoma. So it looks like that right there would be a good fit. Okay, you can tell that this one's too small, as well as that one. That one's too small. This one's a little bit too big, because if I'm leaking stool onto the skin around it, it's going to irritate. Okay, so it looks like that one right there is the correct size. Alright, so I'm going to remember that. I'm going to grab my wafer. Okay, going to then take the size that I had and put it in the center, draw a circle here, and then I'm going to cut it. Cut that hole out. Okay, with a pair of scissors, regular scissors are fine. Then once I cut it out, I'm going to take this off. Okay, turn it upside down. This is always patient side. Turn it upside down. It would fit over that stoma, and then it fits onto the patient. Okay, now a couple of things as you can imagine with that, you have to have clean skin around the patient. Okay, so you can wash it with warm soap and water, let it dry. Well, you can also imagine that if I had this, it's not glue, but this adhesive on my skin, if it was to start peeling off, my skin would become irritated. So after we clean the site, okay, around the stoma, we also use what's called a skin adhesive and a barrier wipe. This creates, not only does it clean it, okay, it's not alcohol, it's a barrier wipe. You can kind of see a film around there, that kind of where it's wet. And when it dries, it leaves a small barrier that the stoma, that the wafer was still attached to, but it protects the skin. Okay, so I've got my correct stoma size, and I've got the wafer in place where that's coming through it. Well, if you notice, there is, take that back out, there is a ring up here. Okay, so I've cleaned, this goes around, it's secure. Okay, make it nice and neat. You fit it over the stoma, push down into that stomach. Okay, Okay, and you want that a nice tight feel, a seal there, so that gas, flatus, doesn't leak underneath and create a smell. So you want a good tight seal around the stoma. Okay, the next part of putting an ostomy is the bag. Bags come in different sizes, and it's based on, this particular one is Convatec here, this wafer, and you want a ring that fits over that ring, the female adapter over the male. So it fits here, okay, it pushes in, and then you have the bag. Now this bag could be tilted here, turning to the side, or it could, however the patient's comfortable. Okay, so that bag actually seals, and this is a different bag for the type of wafer I'm using, but it would actually clamp on, and then you would take the clip, roll this up, clip that, and then this pouch is what collects the feces. If somebody eats a lot of collards, what have you, that bag's going to blow right on up, and you have to what's called burp the bag. You take the clip off, get all the air out, and it smells, yes, just like somebody passing gas. Okay, but that has to be done. Every so often you need to empty the bag, okay, if you're taking in taking output. So over here it could be look like a formed stool. Over if it was on the other side, it could be liquid, and you would have to measure. Okay, so that is how you put a wafer on a patient. Okay, taking it off, you would then clean. This wafer would dry out over a couple of days. It just uses the manufacturer's recommendations on how often to change it, and also the patient's preference. Patients that have ostomies for a long period of time, they're going to tell you exactly how to take care of it. The best thing that you could get in the hospital is a patient that has an ostomy that doesn't mind teaching you, because they love to sit and talk about it, to teach people how it works. Okay, there are societies out there that teach people that have ostomies ways to keep the bag hidden so that it doesn't mess with their self-esteem. Okay, body image disturbance, and all of those things. So what you see over here, okay, are some models that represent ostomies. Okay, and these are just different types that you would see. Okay, so here you would see a little out pouch. You would still measure it the same way I told you, and just when the patient had a bowel movement, it would just come right out of that. Okay, this is the double barrel stoma I was telling you about. Okay, that may be where you use the great big ring to cover both of them. One drains the stool, the other drains mucus. And then you have just a regular stoma. So these are in the lab for you to look at. So come down at some point and take a look at them. I'm going to leave the actual measuring device out, as well as the skin barrier wipes. Try not to open them up and use them, but I'll leave them out, as well as some the stoma adhesive or the wafers. Okay. Alright, and that is pretty much it on ostomy.